Okay, so it's 8 a.m. and I want to officially welcome everyone to At the Intersection this morning. It has been such a great series, I think, on mental health. I've learned so much and I've applied even more. And so I really encourage people to think about this series and how this might be utilized among your own teams or your congregations or organizations. What could you do with these recordings that you couldn't, just do on your own that would really enhance the work that you're doing? And just even taking portions of the recordings, put those out maybe in newsletters, in a link, or whatever it might be. But this series has been just a really is a really important resource that's building up to many things. So we're going to take a couple minutes for a few announcements and an opportunity for more people to sign in. So this series is intentionally connected to all the mental health work that we're partnering and collaborating on across the city. So in those announcements, a week from today, we will still have At the Intersection, but it is also the morning of Sacred's next Action Lab, which is on mental health, partnered with NAMI and CHCS. And our NAMI's Lauren Bird is going to be facilitating the panel that morning. And Hannah, who many of you heard last week, will be keynoting. So that's next Thursday, 9 to noon. And we'll put that link later into the chat for people to still register. Registrations have been so good, so so hopeful. Many of you know when you do events in San Antonio, the biggest registrations, I mean, it might kind of sit for a while. And then the week or two before it picks up, and then like that week, it goes like crazy, right? We have had strong registrations since, a couple weeks ago. And that tells me that the co-laboring and partnering and the need for this is really high, and we're getting stronger in terms of people and San Antonians coming together and being not only aware but engaged in this work. So we've got really strong registrations for next week. Please keep registering, and we hope to see you there. That all flows into the Behavioral Health Conference, annual conference. And Amber might even say a couple words about that, but it's on the 29th of this month. And everyone is welcome to come to that. And continuing on that kind of thread of, broader, larger community, we don't want to forget about Pathways to Hope annual conference, which is August 28th and 29th. I don't think the registrations are open yet, but it's coming soon. And so you can go ahead and mark that on your calendar because it is going to be amazing this year. And Doug has his hand up and just has to say more.
No, just quick question. Next week you said we start at 9, but don't you have the intersection speaker coming in at 8?
Yes, we do. You're absolutely correct. So
So
we're going to still, and he is going to be on uh, integration, therapeutic integration. And so that kind of leads into those conversations about um, centers where they do that kind of integrative work across the country. Doug, you might want to say more about that. So yes, we have At the Intersection virtual at 8, but that leads right into Sacred Action Lab at 9. Doug, you want to say any more about
no,
our
no,
guests next week?
Todd Weatherly with Stucker Weatherly and somebody, and he helps communities set up what initially I was calling recovery campuses, but it's really integrated care within for people with mental illness. And that's kind of his specialty. And that's what Dr. Stucker also was doing. So next week. He's a great resource, and I'm looking forward to hearing from him.
Yep. So if you all plan to do both of those, you two could come, sit in the parking lot and be ready for the action lab at 8. Or, I don't know if I'll be sitting in the parking lot or in a corner somewhere inside with the action lab, but come join me and you can hear that before. We're going to be hearing more about all of these topics in this series, um, both at the Behavioral Health Conference, but also at Pathways to Hope. And we know how all this works across the months and the days. But between now, May, and August, all these conversations are going to grow. They're going to get deeper. They're going to have actions that are happening between now and then. And so the more aware, the smarter we can all be together, the more we know each other, the better we're all going to be, both in our personal lives, but also in our community and professional lives. So um, we're doing good work. We're doing good work. So now I want to turn this over to Amber, who's the Chief Medical Officer at CHCS. And she's going to, just bring us into that jail diversion center conversations that are going on. And so I'm really looking forward to this. Amber, thank you so much for this important briefing.
Thank you all for having me. I'm so excited to talk about this topic. This is something very near and dear to me. I had originally come from Harris Center in Houston, and I had a hand in standing up the Adult Diversion Center and the Youth Diversion Center as we moved along the process. And it was very impactful. It really changed the trajectory of patients' lives, and it was transformational work. And so it's much needed service. It's been a topic of discussion that we've been having in our community for a bit now. So I wanted to highlight and give you guys some information about it and what is it really? We talk about it. Um, and so I wanted to give an overview. So the Bexar County Jail, we're having to send inmates to different jails outside of Bexar County because we're overcrowded. In 2025, last year, there were about 550 inmates we had to send somewhere, but there's a bunch with mental health needs. University is the medical partner, excuse me, at the jail. And so they have a big population they're serving. There's overtime costs for deputies having to wait to process people into jail. And so that's another factor that we look at. And then there's a wait list for state hospital forensic beds, and these are people that have entered the jail system and they need a competency restoration. So they're not restored to go to court and they need some kind of mental health treatment. And so at one point, wanted to look at how can we help that population and started doing jail-based competency restoration. Currently, we serve about 80 people. Most of them are males, but there's some 10 females. And that's really to help restore these people so they don't have to go on to that forensic state hospital bed. And San Antonio State Hospital is our catchment. They serve a lot of different areas. So even though it's a San Antonio State Hospital, it serves far more than San Antonio. And then the hospital they redid a couple years ago, it really opened up capacity for forensic beds, not really civil beds for the community. So sometimes people are landing in the jail, unfortunately, because it's a place where they're going and they get mental health treatment. And so because their mental health is not adequately treated in the community, something may happen, a criminal trespassing or different charges, and lands them in jail, which will keep them there in some holding pattern for a period of time where they can receive treatment, but that's not the best place for them, right? We don't want people to have to go to jail, excuse me, to get mental health treatment. So I thought this was a very nice slide as to how we have designed diversion system. And this is for CHCS and the county and all the different uh, steps along the way as to how did we get here. Really key things to note on this, you're going to have the crisis redesign. It was around 2010. The state of Texas got money for crisis redesign. And so then we started getting some momentum about jail-based competency restoration for those that are housed in the jail. There's the outpatient competency restoration. We started looking at some of our high utilizer teams. So those patients that are going into the emergency rooms or inpatient facilities often. Can we design teams around that to really support the person and help them engage in their treatment, be successful in their treatment without having to utilize those services? Because it's better to keep them engaged at the community level. And the jail is part of that. They stop going in and out of the jail and the ERs as they get better. And so then we also looked at our multidisciplinary crisis teams. And that's really, excuse me, where we are today. We have our San Antonio core and we have a SMART team. And these are our clinicians riding with law enforcement in the field, really trying to resolve on scene some of these crisis calls that are coming through. And it's very effective. It does work and it keeps people from having to go through that involuntary hospitalization experience, going to emergency room, going to inpatient psych. Excuse me, guys, I have a little cough. But we know that can be very traumatic for people. And one unique thing I just want to point out about our community is we have STRAC, the South Texas Regional Advisory Council. And then we are able to utilize STRAC to really be that hub for law enforcement navigation for those beds, the MedCom beds where people need to go on to higher level of care. And so they have done a fantastic job managing that, developing out that system. And it's actually a nationwide model. Other places have not been successful in standing that up. And that is a real testament to our community collaboration that we have here in San Antonio. I can tell you Harris County tried it a couple times and it just had no traction because you couldn't get the key stakeholders to all agree in the room, which is unfortunate because we know how powerful the strap can be. So what does a robust justice system look like? We're trying to hit people upstream. We want to touch them at the highest or the first touch point where they're going to encounter a crisis. And we do know that crises occur with law enforcement. And so that's where some of this is coming from, is we want to really divert people from having to go into the jail. So if you can hit them at the pre-booking and they can go on to a 2-week residential program, then we can really have the impact there. So I'll get into some of that as to what it would look like in a minute. But we really want to hit them before they get booked into jail. That's the goal. And so what does a diversion center look like? So you hear diversion talked about a lot. Sometimes it's called deflection. It's much the same thing. It's really having the impact before the booking. And so in the Harris Center model is one of the national models. People came from all over the US to look at it. It's a very robust system. And so there were 2 phases to that. The phase 1 was law enforcement drop off. So law enforcement would encounter a person in the field. It was a criminal trespassing, criminal mischief, low level misdemeanor charge, and would say, know that they have a mental health history from the jail record and say, hey, Joe, can we go to jail diversion instead of booking you into jail? And oftentimes these patients may be struggling with housing supports, family issues, whatever the case may be. And so they would send them to the Jail Diversion Center. And we had a peer engagement specialist at the front door, really trying to help retain and engage that person. We had a medical nurse do a triage to make sure they're medically stable. If they were not, we took care of it and sent the person to the medical facility if they needed some medical care, and we let the officer go. And that really decreased the overtime for law enforcement. So that was a win for law enforcement as they could get back into the community doing the work they need to do. And then we would, for those that were medically stable, we'd check them in. And the next day, a primary care physician would see them. Everybody got checked out by primary care because we know these patients often didn't have their primary care needs met in addition to their mental health needs. And then they had opportunity to see a psychiatrist. Um, and you didn't have to. So, some patients, and I saw these patients in Houston, some patients would come in and they would say, I don't need psych meds, and say, okay, it's voluntary. This is your treatment journey. Let's work with you on what your needs are. And so sometimes that was housing, or SNAP benefits, or maybe they need an eye appointment, or they need to see the dentist. So all those wraparound services were very important to help with the coordination piece. The therapeutic side of it, while they're there for about 2 weeks, was 5 to 6 groups a day. And a lot of these patients often had comorbid substance use. So we had some substance focused groups. We had some peer led groups. We had activities. There was a outside green space with some workout equipment, a garden, different things that are therapeutic and can be done in one of these facilities. And so it really was a holistic experience that we were trying to get at. And so looking at a facility as we're going through this here in San Antonio, I am looking for something that has something with a green space. You don't want it to feel like an institution, like a jail. That's not the point of this. So it was something voluntary for these patients coming through. Sometimes they turned around and left after 5 or 10 minutes. And that's okay. They would come back. And eventually, after the second or third time, it would stick. And overall, it was a very positive experience for people. And so once they had their treatment, they got their needs met. We said, you're good to go. You've completed and graduated this program. 2 weeks later comes, then we would have a 90-day aftercare program to really help assist with the wraparound services to ensure their success in the next step of care. And so it would be one of those pathways where either it would be depending on what they have. If they have insurance, they could go out, with the private sector. Sometimes they would go through the enrollment with the local mental health authority. Sometimes they would go through a care link, like with the hospital district, which would be University Health. So it was a very successful program. It's going to look a little bit different for us. But overall, the big goal of it, coming back to this slide, is you want to reduce your overcrowding in the jail. That's not the best care setting for people going with a mental health issue, going through a low-level misdemeanor. It delays the care. Our system here, we have the dual magistrate, which causes additional time before they can actually get their needs met. And the biggest worry is suicides. People can't get the right care at the right time, and an adverse event occurs, right? So we want to really try to give people the care they need, keep them out of the emergency rooms, keep them out of the jails, and it really improves their outcomes. So, and from a cost perspective, it also improves our overall healthcare costs as a community. And then the collaboration is a community effort. So sheriff's office is going to have a heavy hand in it. SAPD, your other municipalities, usually those will follow after you get it stood up. District attorney and is going to be vital in deciding what charges would qualify someone to go down to a jail diversion program pathway instead of jail. And then your other, community stakeholders. So our cost analysis in this, I pulled down from Harris County. So in Harris County, to house and treat one mental health inmate or detainee at the Harris County Jail, it was a lot of money. And so we pulled the Bexar County Jail cost, which is $17.50 a day, and pulled down what it costs to treat one person per day at the Harris County Diversion Center, and it was $510 a day. So there's a total cost savings of $1,240 a day. Um, that's a lot of money saved for the jail. They aren't having to have overflow inmates going out of county to different jails because they're at capacity. Um, and so I think there's a lot of upside to developing this out here. Um, so we have, because so Harris County had 36 beds. I don't know what we're going to land in San Antonio. So we have enlisted Dr. Testa with UT Houston to do a feasibility study for us. And he's in the process of that. He also did the study at the jail recently. So he's got the data warehouse to pull down for that already at the fingertips. So that was great. We want him to have this feasibility study back to us by the end of summer is the goal. And really what we're looking for in this feasibility study is the cost and how many beds are recommended for our county, because our jail serves over 5,000 inmates. How many of those are coming through with a low-level misdemeanor that we could divert out, and that will help determine the bed capacity that's going to be recommended and the cost to go along with it. This Harris County 510 a day data, we stood that up in 2018. That was 8 years ago. So I anticipate the cost has probably risen a little bit. I think your cost savings will still be about the same, just due to inflation. Okay. All right. So mental health in Texas. So Texas, interestingly, is facing a federal lawsuit because people were waiting in the jail so long for a state hospital bed. Um, and this is where the jail-based competency restoration comes in, the SASH renovation. The renovation didn't add actually extra beds, is the unfortunate part of that story. SASH has 45 beds for the community, and it serves 54 counties. So it's something that, even though it says San Antonio State Hospital, it's a forensic hospital for the state. So SASH, looking at hospital closures and bed status in our community, SASH has closed 40 beds back in 2019 for the children and adolescents. And then NICS went offline also that year with 164 beds. Then Texas Vista in 2023 with 50 beds closed down. And then recently, and you all probably have seen this, is Laurel Ridge has had to close down their facility largely. They're keeping 10 to 12 beds right now for just cash pay or unfunded patients. But they lost their Center for Medicare and Medicaid status, CMS, which is a very big deal. And so that means insurance companies, our federal CMS will not pay for any patients going to receive care there. So there were some safety issues, and that's how that happened. So here's our Meadows study. So University Health did a Meadows study back in, I thought it was 22, but this says 24. So they conducted a study, and this was previous to Laurel Ridge closure, but really showing a gap of inpatient beds by 227. If you compound that with the recent closure of Laurel Ridge, that's just accelerated the lack of inpatient beds for our community. And the reason this is important is we're very worried about patients not getting the right care in the right setting at the right time. And so that's, let me go back if I can. So the continuum of care is going to need to be enhanced, and that would be where your jail diversion program would fit into that equation, is we could deflect some of these patients from jail. We could deflect them from needing inpatient care, and really provide a valued service to people that will help them in the long run. So if you look at the 227 gap and you add Laurel Ridge with 330 bed closure, I mean, that's huge. That's 550-ish beds that were at a shortfall as a community. And so it is a crisis at this point. And we've been working strategically with STRAC to come up with a short-term and a long-term plan. Because the closure of a hospital, we can grease the wheels with our continuum, but we can't make beds magically appear. That's a process. So looking at all those things, and the Chamber of Commerce met this week also in support of however we need assistance with the inpatient side. But the jail diversion part of that is very important. So it's multifaceted approach, not just one. And so, as Bear County is growing, and this is the last slide, I know we're running out of time, the demand for inpatient care is outpacing any of the resources we have. Um, I'm very worried that the Medicaid requirements are going to have impact with more uninsured patients because now patients are going to have to reapply their status every 6 months. There's just more barriers, it feels like, to remain with Medicaid and disability. So I'm very concerned our uninsured, which we've already been seeing, is going to continue to grow. And our patient population is very vulnerable. We want to make sure that people have access to care, that they can go and get their needs met without having to go to an ER, without having to go to a jail or inpatient care. So in Bear County, we have 1 in 4 adults with a mental health condition. At the center, we treat the serious mental illness. And so that would be 1 in 5 adults with a serious mental illness. And more than half of those are below the poverty line. And so our safety net population currently is about 400,000 residents. Medicaid is about 180,000, and that's declining because of those Medicaid additional requirements now. And if you think about the outpatient arm of all of this with the Center for Healthcare Services, we treat 36,000 or so people a year. It's just not near enough, right? According to this data. So I'm really excited and hopeful about the jail diversion program because it does, it speaks volumes. And as a physician treating patients in Houston in that program, it was very rewarding to see the progress people were making and their recovery journey. They were actually able to engage in treatment and get into recovery, whatever that looks like for that person. So I'll open it up for you guys. I know there may be questions.
Amber, this was perfectly amazing, or amazingly perfect. The timing, of course, couldn't be any better. All that information on Laurel Ridge is so disconcerting for our entire community, and so timely is not even the word. It's something more like urgently, right?
It is. Yeah.
Right. So yes, we want to open this up for any conversation and questions. We just have a couple minutes before 8:30. I don't know, Amber, if you can stay with us for about another 10. Okay. But I want to make sure everybody knows, take just a brief moment in case people have to leave, but where there will be at the intersection next week. And it's going to be on integrative therapy, wraparound, how that works with families, community. So that will be at 8. The doors open for the Sacred Action Lab at 8:30, and the Action Lab starts at 9. So I just wanted everybody to know we're on our mental health path. So hope to see you next week. I see that Mr. Roth has a question and his hand is up.
Yeah, my question was, is there any data on tracking the long-term effectiveness of this program? I mean, I know the short term is it's so much per day, but how does that population do long term? I know some probably relapse, but is there any tracking on that, and where would we find that kind of data?
Yeah, well, and that's going to be part of the feasibility study that Dr. Test is doing. And he's pulling down not just Harris Center, but other diversion centers across the country. So, at the Harris Center, I don't remember the number. It's been 2 years, you guys. But it was, I want to say in like the 60 to 70% range of successful outcomes. So it's pretty good.
Peter, your hand is up.
Thank you, Ann. Thank you, Amber. Great work. Question about the Houston model. You said you helped stand that up, so that I mean that's great that you were able to see it through. And I know when we've had conversations before about the process for getting it funded, right? And how did Houston come about that? What was the campaign, and where are we at in that track here in Bexar County? And I know you mentioned those partners, and I think that's really critical. Of course, working, Doug and I have had conversations about how we build that support from with this kind of work here, which is great. So yeah, that's my question.
Yeah, and that's a great question. And the funding, it may look different for us in San Antonio versus how Harris got it stood up. The large portion of funding for Diversion Center came from the cost savings from the Harris County Jail, which would have been the sheriff's office. And so that's exactly why that data was pulled, so we could look and see what is your cost savings in the jail. It also reduced their suicides at that time. There were several suicides going on in the Harris County Jail. There was a lot of pressure from the media, and the cost savings component. We were able to make a case and get the sheriff's office to be one of those main contributing factors. We also had some grants from Health and Human Services in Texas. That was additional support. What we were running into when I left is costs were increasing because of inflation and all the things. So your laundry, your food, all the things you need for diversion center operations were going up in the contracts, and our funding was flat. And so we were trying to see how can we remain at this level and continue to provide the care. So we were getting creative on applying for additional support. Some of it was philanthropy, some of it was county, when I say county, like the hospital district. So I think it will, the feasibility study will help us make a case for our partners coming to the table and doing their contributions. That's at least my goal and my hope for this.
Well, thank you, Amber, and look forward to the pathways to hope as we're working toward that and what might come from that, expanding even the exposure to this plan.
Yeah.
Thank you.
And I'm hoping by the time Pathways comes, we've got the results from feasibility, so we can talk about that on the panel there.
Perfect. Thank you.
You're welcome.
We're getting far too good at, working together. Can we get far too good? I love that whole thing. Hopefully by Pathways to Hope, we'll have reporting on in the panel there. Oh my gosh. And then when we think about, so I'm diverting a little bit, but it comes right back to the diversion center, right? But as we grow these collaborations, that's when they really become important, like with the Jail Diversion Center. If we thought for a moment, and somebody with better math skills than I have, but just in the partnerships that we have, in probably with the behavioral health conference, but especially I know with Pathways to Hope, the number of organizations that are working on that around the table, and the number of people in those organizations that are also working on it, that is a huge collaborative. When you add in then the community that's also a part of it, and not coming together, like in meetings, but working together, that's huge. And it says a lot about who we are in San Antonio and who we are becoming. So I get really excited about collaboration. I know I'm a collaboration nerd. Is that possible?
Well, we work better together, right?
That's right. It's the only way to get it done. Do we have some other comments, questions, kudos? I'm just so grateful, Amber, for you and the work you're doing.
And it looks like Ashley has her hand up.
Oh, great. Ashley.
Good morning, everybody. Amber, I'm really grateful to be here. I'm thankful for your presentation. I myself am a peer professional. I work with folks that are on Bear County probation. So the information you've shared here is pretty invaluable. And I wondered, I'm in outpatient treatment. I wondered if I would be able to get your contact information and or your slides to share with my team. Would
Okay.
that be possible?
I don't see why that would be an issue.
All right, I'll do you one better. I'm also plugged in with Strack, but I am meeting with Rosk next Monday, and a huge portion of our conversation is going to be in regards to the bed loss at Laurel Ridge. I wondered if the information you provided here could also be shared with those folks.
So Strack already has this.
Um, ROSC, the Recovery Oriented Systems of Care, that's a bunch of community partners centering around mental health and recovery support services.
Mhm.
I knew Strack would, but this organization, this group, they're meeting on Monday. And I wondered if I could bring this information to share with those folks as well.
Let me check with my government relations team before
Okay,
we start circulating things. But I
sure.
don't think it will be an issue, but let me
Okay.
double check.
One thing keep in mind, Ashley, is that this is recorded.
Mhm.
Yes, ma'am.
So you could utilize this recording and send
True.
out the link
True.
to whoever's coming, or normally that link is up by Monday, and we can put into chat where you can find that.
Hmm.
So you could actually have Amber show up, but recorded Amber would be
No,
showing up.
that would be great. I just wanted to make sure I asked, for consent, obviously. And
Yeah.
then those community partners on Monday, those are members of like TAP and other recovery support professionals like myself. And again, we're just speaking explicitly about like the loss of beds at Laurel Ridge and
Mhm.
how to offer more wraparound services and kind of fill in the gaps. So just really relevant information today, regardless of all of the answers. I appreciate you and the work you do. Thank you so much.
You're welcome, Ashley. And just a couple things, because I chair the Behavioral Health Committee at STRAC. We did a think tank last Friday as to how can we work on some short-term response to Laurel Ridge closure. And we did talk about various things. There's a Good Sam pilot that we launched on Monday with our SAPD mental health unit.
Hmm.
And it's a link connecting law enforcement directly to a clinician in the field and getting the needs met. So far, it's a small pilot. We're tapping into existing staff. There's no funding at this stage,
Hmm.
but the ones we're resolving on scene are pretty powerful, and
Beautiful.
patients are getting their needs met. I think one got a bridge prescription, one got connected
Mm,
to the Haven. And so it's very early on in this pilot, but we're trying to upstream hit on preventing people from going into inpatient level care if they don't need that level of care. If they need inpatient, that's a different thing altogether. But we've got
beautiful.
that. We've got the Medcom queue. It's been growing. The numbers waiting in the EDs for beds have been growing. Yesterday, when I looked at that queue, someone had been there 10 days. And so can I have a behavioral health assessment team manage the queue and reassess? Because I know when patients land at the ER, they get slated for inpatient and they often don't change course. And they may be sitting there getting better because they're receiving treatment for
Hmm.
that however many days. So looking at some creative ideas there, um, there were many other things in our continuum that we're looking to really enhance direct admissions, direct referrals to get people to residential level care, to detox, to different areas that we could. And it's not going to solve the 330 beds going offline, but it
Hmm.
will ease some of the heartburn and help with some of the resources and bring us together stronger in the community.
I
Beautiful.
noticed that Ashley and everyone else, but that Billy put into chat where you can find the recordings from at the intersection. So you might copy and paste that and save it somewhere. Doug, you have your hand up?
Yeah, and Dr. Pastusek may have already kind of touched on this, but as I was listening, one of the things I heard was um, instead of going to jail, you can get 14 days of outpatient treatment followed by 90 days of further support to help with the support services and systems that people need. And it reminds me of the comment that people have made over the years in the community, which is, well, if you want to get mental health care quickly, just go to jail.
Yeah.
And I think that the work that maybe you're doing right now, and we're trying to figure out how to manage through this crisis, I'm hoping that that will give us some insight into those things that those 400,000 other people in our community need. Why do we have to wait for them to get in crisis? Why do we have to wait for them to go to jail? Let's just treat people in the community like we're going to, like they're going to go to jail, and to see if we can't provide better services. That to me is a big uh, question and the crux of how do we handle, mental health needs moving forward in our community. Amber, do you want to expand on that?
Yeah, and that's exactly the title of this series. That's the intersection of mental health and law enforcement encounters, emergency room, acute care. We want to be that intersection where they don't have to go those pathways. Because I don't know about you guys, but if I were getting taken to jail or to an emergency room on an involuntary emergency detention, that's pretty traumatic. And I shouldn't have to resort to that to receive care. I should be able to have the access points to get that care at the right time and the right setting and the right place, right? So we want to make sure we're providing that. And I think that's where your development of the continuum of care will really help offset and bridge that intersection, because it's not good for people to have to go through that experience.
Thank you.
And it just sounds horrific, right, Doug?
Yeah.
When you said, go to jail to get those needs met.
I've heard it so many times from patients, or they say I have to say I'm suicidal to get my meds, and they're not really suicidal. They've just been, it's a wait to get into the clinic, and the outpatient side, maybe they don't know where to go. And so you want to really provide them with those resources so they don't land in crisis. Because I mean, ultimately, that's what this is coming to, is a crisis. So.
So I just want to thank everyone, and Amber, Doug, thanks for helping to set these up and collaborating together, and excited for CHCS that Deirdre's going to be with you. We're just all getting stronger,
Yes.
working together, and I feel more hopeful because of the collaborating in the context that we are now in, which can be a place of dismay and discouragement. But thank you for all the work that you do, Amber. I want to thank everybody who's with us today and for all the work that you do for showing up. I invite you to even ask yourselves, and then we're going to sign off, but to take some time to reflect. Why do we show up? Why do you show up? Why are you really showing up to this work? What is that? And it's important to know that if you don't. And to maybe even share it with others and find out why they show up. And then that helps also, I think, to strengthen our collaboration. There are reasons. There's family, there's friends, neighbors. And so I'm going to finish with that. It's another beautiful day in San Antonio. I actually have a green yard now. And that is just like I walk out and it's like, whoa, because it's been so long since I saw it. So enjoy the beauty of our day. And remember that we're all a part of that beauty and making that happen. So have beautiful days, great weekends. And I will see you next week at the intersection, but also at the Sacred Action Lab. Thanks all. Bye.
Thanks for having me.
You bet, Amber.